Hi, everyone, and welcome to today's National Neonatal POCUS Collab webinar. My name is Tammy Tran, and I'll be your moderator today. Before we start, just some general housekeeping items to make note of. The chat is disabled for the audience, but the moderators may send out general announcements via the chat. For questions, please use the Q&A function to post questions, and there will be a Q&A panel session after our featured presentation. This webinar is being recorded and will be uploaded to the website at neopocuscollab.com. Now, on to our main talk. It's my absolute pleasure to introduce Dr. Evan Baum. Dr. Baum is a clinical assistant professor in the Division of Hospital Medicine at Stanford University. He's focused on medical education, point-of-care ultrasound, and integrating AI into bedside care. He co-directs Stanford's POCUS curriculum and leads research on AI-assisted ultrasound acquisition, diagnostics, and training, including randomized trials in cardiac imaging. Dr. Baum, welcome, and please take it away.
Thank you so much. I'm just going to share my screen here. All right. Folks should be able to see my screen. Um, Thank you so much for the invitation, the opportunity to speak on this topic. I'm really excited to share some emerging applications of AI and point-of-care ultrasound. And I look forward to the panel discussion after my talk. First, I have no financial interests to disclose. I do, however, have a personal disclosure. I have never scanned a neonate. I'm an adult hospitalist with a passion for POCUS, particularly applications in AI and POCUS in medical education. But I'm hoping that these concepts will span age and that these tools will be of interest to you in the neonatal world. With that background in mind, when I was preparing for this talk, I reached out to the neonatologist who I know the best. And that happens to be my father-in-law. He's actually a retired neonatologist outside of Chicago. And I asked him to reflect on how ultrasound changed his practice and what it was like learning ultrasound as a neonatologist. And he shared that, he was doing his residency and fellowship in the early to mid 80s. And ultrasound was very new, especially in newborns. It was rare to have an ultrasound on the unit. It would be brought in to the floor by the tech and then back while you waited for the report. And once there was a machine on the floor, it was this big unit that they had to drag around. He predominantly learned ultrasound from sonographers, and he would review studies with radiologists. Some attendings were starting to become interested in ultrasound. So sort of understanding the past, these big machines, this is the first Siemens machine to display real-time heart images in B mode, to now where we have these machines that fit in your pocket, that are wireless, that can, show images on your phone or tablet. How did we get here? And now that we have these machines, they're all incorporating, a lot of them are incorporating AI. So why AI and POCUS? POCUS is everywhere. There's, so many handheld devices, cart-based machines, different operating systems, and this creates a large competitive landscape for innovation. And there's adoption across multiple clinical settings, but still there's a lot of operator challenges, variable image quality, educating new and novice users, standardizing workflows, and then an administrative burden that AI could potentially help with. And a lot of the systems that I talk about they use deep learning, which are also known as convolutional neural networks. They're trained on these data sets of thousands to millions of images, and they learn to extract features, anatomical patterns, and they recognize these features in the same way that, the human visual cortex would recognize them. There's also a huge market for AI in medical imaging. In 2024, estimated at over 2 billion to in 2034, expected to jump to over 30 billion. So AI in medical imaging is already here, and it's just expected to grow exponentially. Now that I've shared some background on why AI and POCUS, I want to cover the following in my talk. Describe emerging applications of AI in image acquisition and guidance. Review AI-assisted interpretation tools in POCUS. Discuss how AI can affect workflow, quality assurance, and billing. And then consider opportunities and some important limitations of AI in POCUS practice. And I know it's a webinar. As we go along, I'll ask you some reflection questions, things to think about to yourself, but feel free to throw in comments in the chat. And perhaps some of these reflection questions can spark conversation for our panel. So first, let's talk about AI for image acquisition and guidance. I talked a little bit about the problems, POCUS being highly operator dependent, your probe orientation, angle, depth, and novices often struggle to obtain standard views. Historically, skill acquisition requires supervised mentorship, real-time feedback at the bedside, which I would still argue is the best way to learn POCUS through supervised practice. But this is hard to scale. And so the question is, can AI act as sort of a virtual mentor for image acquisition? After training on these thousands of images, can these systems give feedback on image quality and provide probe manipulation instructions to take users from images like this, which is a foreshortened apical four-chamber view? And some of the images clips may be a little bit glitchy on the webinar, to images like this one on the right, which is an optimized view. So let's look a little bit first at AI-guided lung acquisition, which is a little bit newer and still developing compared to cardiac. But there's a lot of, I think, potential applications in neonatal POCUS, and I'd love to hear from you about them. But including respiratory distress, transient tachypnea, pulmonary edema, or infection. You can imagine that technology like this could help standardize probe position and clip acquisition in the NICU. And these are just some clips of in adults of B lines on the left and then A lines on the right. So what do these tools look like and what is some of the evidence? So Balescu and colleagues in 2025 developed this AI lung ultrasound system that they tested with healthcare providers, non-MDs. These were MAs, RTs, and RNs. And they had them use the tool to perform lung ultrasound on 176 patients. And they compared this to expert-acquired studies. And they were able to achieve over 98% diagnostic quality with no significant difference. And these results were consistent across a diverse patient demographics, BMIs. And I'll show you the system a little bit. You can see that there's a probe position, basically an anatomical reference telling you where to scan. In this case, I think it's an 8-zone lung scan. There's a reference image that shows you kind of what to look for, the pleural line, A lines. There's landmark guidance that's showing you the pleural line, showing you where the ribs are, where the lung fields are. There's messaging about kind of holding the probe steady, moving the probe. And then there's a quality meter that shows you kind of the quality of the scan. And once you meet a certain quality threshold, then it will auto capture your best image. This particular system also has an auto B-line capture feature. In this study, the acquisition time was about 15 minutes for the less experienced users and 8 minutes for the more experienced operators. But you can imagine that this time difference may be inconsequential in more resource-limited settings where the alternative is no ultrasound at all, or waiting for a sonographer scan or subjecting somebody to radiation or another type of scan. This is a brief video of sort of what that looks like. And it's just basically highlighting the pleural line, and then it's highlighting sort of what A lines might look like. It's telling you to hold the probe steady and giving you some feedback on your progress. So the reflection that I'll ask is, could AI guidance enable POCUS in smaller NICUs or lower resource settings? Could these images then be remotely interpreted, or could they be interpreted with the help of AI? And we'll dig into that a little bit later. I want to shift now to look at key tools in cardiac acquisition, which is a bit more developed, and just show you a brief video of sort of what this looks like. So again, on the screen, there's instructions about how to rotate or move the probe. Um, there's basically an anatomical reference and an optimized view that it's showing you. And then from there, once you obtain a certain or once you hit a certain quality threshold, then it will essentially automatically capture the image. Um, and this has been studied. So Narang and colleagues looked at this particular software. They studied it in 8 nurses without any experience. They did tell them how to use the software, and then they had them obtain 10 view echoes on a total of 240 patients. They controlled the study with sonographer scans without the AI software, and then they had 5 expert echocardiographers who were blinded to the scans assess whether each were of diagnostic quality. And in this study, they achieved diagnostic quality for LV size and function in over 98% of scans, with no significant difference between nurse and sonographers. The exception was looking at the IVC, where only 57% of the scans were diagnostic. And this will kind of become a pattern in the 3 studies that I'll mention. This is another example of kind of AI guidance image software. In this case, again, there's an anatomical reference in the upper right. It's telling you how to move the probe. And then once you obtain a quality view, there's a quality bar, and it's telling you to hold the position so that you can obtain a clip. Moravi and colleagues, same study design, 6 nurses and 3 residents this time, and they obtained 99% sufficient quality for LV assessment, and not significantly different between sonographers. With the exception of the IVC, where only 68% of scans were diagnostic quality. So we're starting to see a pattern here. This is the last cardiac acquisition study I want to mention. Here, you're seeing there's a target on the screen, and the user has to basically manipulate the probe to obtain both, in this case, a peristernal long and a peristernal short axis view. Similar on-screen guidance and feedback, and then an auto capture feature. Um, and when they studied this, same study design, 100% of the exams performed by novices met the quality standard for LV analysis, RV size, and then looking for a pericardial effusion. The exception again was for the IVC. And one of my takeaways from this is, perhaps for less technically challenging scans, the AI assisted guidance is performing well. For more complex or nuanced scans, for example, for looking at the IVC, the aorta is right nearby, and perhaps the novices are, confusing that, or the AI, hasn't been trained to discriminate those features, or you may be non-tangential to the vessel and not getting as high quality a scan. So there's still some work to be done in this space. Now that we've obtained our images with AI, how can AI help for image interpretation? And this is an evolving landscape where there's a lot of different applications in cardiac, looking at LV function, looking at VTI and IVC collapsibility. For lung, looking at the pleural line, looking for B lines and pneumothorax. For vascular, looking at DVTs. And then a whole host of other applications from, gestational age estimation to screening for common things like congenital hip dysplasia or looking at thyroid nodules. And, it's exciting to think that AI could help us interpret and be clinically integrated into our workflows. So I want to start again with lung, seeing as it may have the most overlap between adult and neonatal populations. Um, the same, group that I mentioned earlier looked at their automated beeline quantification. They found, pretty good test characteristics in terms of sensitivity and specificity for beeline presence or absence, and good agreement with expert reads. This has also been looked at in the ICU. So Dave and colleagues looked at 100 ICU patients. Again, really good test characteristics for distinguishing A lines versus B lines with AI. And then there was another study where they actually looked for the diagnosis of absent lung sliding. They found high sensitivity, solid specificity, and good discrimination for the diagnosis of absent lung sliding. You could imagine using this in a patient where you've placed a central line or where you've done a thoracentesis or they've had a chest tube, and then you need to assess, if there's a pneumothorax. You could do this quickly with the assistance of AI. And you may be able to spare that patient a chest X-ray exposure to radiation, or may be able to make the diagnosis in a more timely manner. So what does this look like? Here's a video clip.
AI system, never before seen, speed and accuracy.
And it's basically just assessing the pleural line. It's telling you if there's lung sliding present. But importantly, there's also a user determination. We're not taking humans out of the loop, and we always have to, see what the AI output is and if we clinically agree with that. So there is also a user determination, and you can replace the read with your own. Um, for AI interpretation of LVEF, this is one of the more studied aspects of AI interpretation, as in cardiac imaging. So he and colleagues did the first blinded RCT non-inferiority trial. They looked at an AI tool versus a sonographer assessment of LVEF, which is kind of an interesting, gold standard. And they found that the AI performed better than the sonographer group in this context for estimating LVEF. Motazian did a prospective study of an AI POCUS system versus TTE for grading LVEF severity. And there was excellent agreement compared to TTE, and good discrimination at the 50% threshold with, great test characteristics. And this is, evidence that AI interpretation of LVEF could be a strong screening tool if you're using a 50% threshold. Just this year, there was a systematic review that kind of looked at AI test characteristics, good agreement, moderate to strong agreement between, experts and AI, and then classifying at a 50% threshold, still good discrimination, sensitivity, and specificity. So AI seems right now that it's positioned well as a screening tool, not necessarily a replacement for comprehensive echo, but you could imagine using this in patient populations, say patients coming in with symptoms of heart failure or in patients with syncope where TTE is often overordered. You're able to do a screening test and better triage who is going to get a formal study and who would best benefit from that. This is an example of an AI tool that helps calculate VTI or velocity time integral. So essentially, the tool, you're putting the pulse wave over the aortic outflow and the apical five-chamber view, and then it's automatically determining where it has to take a measurement. You don't have to adjust that, and then it's giving you a tracing of the VTI that you can then use to estimate cardiac output. So really interesting tools being integrated into POCUS and cart-based machines as well as handhelds. This is a shifting from cardiac, just some other applications of AI interpretation tools. So in this study, they looked at a gestational age estimation tool, and they took, again, novice users. They had pregnant patients between 14 and 27 weeks gestation. And these novice users were able to accurately estimate gestational age with this low-cost handheld tool, with no significant difference compared to sonographers who were performing standard biometry on high-spec machines. And these findings have an implication for obstetrical care in low resource settings, and help kind of advance the WHO goal of using ultrasound to estimate gestational age for all pregnant people. So I'll show you a brief clip of kind of what this looks like. But in this video clip, essentially, they're doing these sweeps.
They loop videos by the software.
And they're doing complete blind sweeps in multiple directions. The user's not actually seeing the ultrasound images, but in the background, based on the training of the ultrasound of the AI system, they're able to process those images in the background and then give a gestational age, which is, kind of interesting that you're not even seeing the images in this case. These are some other applications I mentioned. Screening for congenital hip dysplasia here, it's giving you kind of advice. And then thyroid nodule screening, it's giving you different characteristics of thyroid nodules, measuring them, and then kind of giving you a score, TI-RADS score. So you can imagine multiple different screening applications for AI interpretation tools. And I would be remiss if I didn't mention just a few studies looking at AI interpretation tools in neonatal POCUS, and I'd love to hear about your thoughts on them later on. But Perry and colleagues looked at 62 newborns with respiratory symptoms, and their AI model was trained on a lung ultrasound image database. And their AI system was able to generate scores that closely matched clinician scores for the need for CPAP and surfactant therapy. And this was the first validated AI model for interpreting neonatal lung ultrasound scans. Lynn looked at a deep learning screening system for cerebral lesions, again, trained on over 8,700 images. And this system outperformed junior radiologists and it matched mid-level radiologist performances with faster, with greater efficiency. And then when they let the junior radiologist, a different cohort, use the AI tool, they actually had improved diagnostic performance. So it's showing you that clinicians, with the assistance of AI, could perform better. And multiple different applications, I think, in cranial ultrasound. And then Erno and colleagues looked at an AI model on echo clips from preterm infants, and they were able to use their system to classify the presence or absence of PDA with sensitivity of 83% and specificity of 89%. And so from this, the reflection question that I'll ask is, how might you use AI interpretation applications in neonatal care? And furthermore, would you trust the results? And if you are not trusting the results, then what kind of studies would help that trust grow? Now that we've talked about image acquisition and image interpretation, I want to talk a little bit about AI for POCUS workflows. There's a huge administrative burden of POCUS. There's archiving clips to the EHR, which can be manual. There's typing or dictating POCUS notes. POCUS directors are, a few a few experts are often tasked with manually reviewing studies. There's a lot of credentialing efforts for logging exams and tracking competencies. And then there's a whole billing and coding space that could be, assisted, could be improved with AI without taking humans completely out of the loop. So this is an example of an AI workflow tool that essentially takes POCUS images and then essentially helps create an echo report. And I'm not sure if this clip is running, but essentially the tool takes POCUS images, it creates an echo report, and then a user will go through the images and sort of agree or disagree with the AI output. And we actually tested this software as part of a diagnostic comparison study. We looked at 70 patients who underwent both a POCUS exam and a formal TTE, and we found substantial agreement for LVEF, with lesser agreement for RV function, IVC diameter, and valvular assessments. So there's some support for these sort of generated echo reports. But it's useful to know that there really need to be further studies to compare to gold standard tests. And it's really important to keep expert interpreters on top of these outputs to make sure that they make clinical sense. Um, this is a tool that is a DBT workflow tool. And essentially it gives it gives the user guidance on where to perform the DBT exam, when to compress, how hard to compress. And they looked at this in novice users with only 1 hour of training. They obtained images with AI guidance for probe positioning and compression. And then these images were sent to an expert interpreter, like a radiologist or a POCUS certified EM physician. And their study found really excellent test characteristics for ruling out DVT, sensitivity of 90 to 98% and a negative predictive value of 98 to 99%. And importantly, scans were non-diagnostic about 20% of the time. But still, you could imagine the ability to rule out DVT with POCUS performed by a novice user or in a remote setting. It may help with cost savings and resource allocation, again, especially in resource limited settings. And if the video plays, this is sort of what it looks like. But the system identifies the vein, tells you to compress. It will capture a recording of that compression, and then it will send that image. It basically will send it into the EHR, into your PACS or similar image system for interpretation. So the reflection that I would ask is, what would you want to see AI help with in your POCUS workflows? I want to take this last section to look ahead at opportunities, limitations, and then ethical considerations in this space. There are a number of limitations to this technology. There's an over-reliance. Basically, clinicians can defer to the AI without critically appraising their results. This is common with any technology. It's automation bias. Um, there can be a bias in the training data. A lot of these models were trained predominantly on adult, European or American populations, and they may underperform in pediatrics and neonates, and they may underperform in underrepresented groups. There's a concern that AI could erode skills, particularly for complex exams. And then who's liable when AI-assisted interpretation is wrong? There are data privacy concerns about patient data, especially in these proprietary systems. And then, as I mentioned, like similar to that gestational age model, but many models have these black box algorithms where clinicians may not understand or know why AI made a recommendation. And sometimes they may give you a value without necessarily giving you a confidence interval to let you know kind of how confident you should be in that recommendation. But still, there's a lot of opportunity. Increased accessibility of AI, lowering the skill floor, integration into wearable and portable ultrasound systems. Imagine remote monitoring or remote AI guidance for under-resourced areas. Multimodal AI combined with patient data to help you support different clinical decisions. And then there's a growing space in patient-performed ultrasound. There's FDA submissions for handheld devices that patients can use at home, and you could imagine that AI would help a patient perform their own ultrasound exam. A little scary to think about that, but it makes a lot of sense in some contexts. And then for neonatology, could this democratize POCUS in community NICUs and standardize some of the exams that you do most frequently? So the take-home points. AI POCUS is here, and we talked about tools for guidance, interpretation, and workflows. Evidence is strongest in the cardiac space, and it's growing in lung ultrasound. And there's definitely a need for more pediatric and neonatal data. These tools will always augment and not replace clinical judgment and foundational skills. And the neonatal POCUS community has an opportunity to help shape validation of these tools and how they're going to be employed and used in your patient population. I wanted to thank you for your attention, and I'm looking forward to questions and our panel discussion. And with that, I will stop sharing my screen and turn it over to Tammy.
Thank you so much, Dr. Baum, for such a wonderful and engaging talk. We're now going to move into our Q&A expert panel discussion, so please feel free to put any questions into the Q&A and I'll relay them to the panelists. Joining Dr. Baum today, we have the privilege to have Doctors Dancel, Rios, and Tay. Dr. Ria Dancel is a professor of internal medicine and pediatrics and the associate program director for the MedPeds residency program and the director of point of care ultrasound education at the University of North Carolina at Chapel Hill. She's active in research on AI in cardiac function. Dr. Danielle Rios is a clinical professor of pediatrics in the Division of Neonatology at the University of Iowa. She completed residency and neonatology fellowship at Baylor College of Medicine and a fellowship in targeted neonatal echo at the University of Toronto. Her academic focus is the improvement of outcomes in extremely low birth weight infants through predictive analytics and hemodynamics. Lastly, Dr. Tama Tay is a pediatric emergency medicine physician, NBME AI Research Fellow, and the founder of the AI Incubator at the University of Kentucky. He built UK's campus-wide modern AI literacy and practical skills course and is developing AI systems for ultrasound, medical drones, and public health across Kentucky. Welcome to all of our panelists. I'd like to start the QA session by asking all of the panelists, how do we handle discrepancies between clinician interpretation and AI outputs? And also, have you ever disagreed with an AI output, and what did you do in that situation?
I mean, I think all the time, like the tricky thing with AI is AI is only as good as the data that it has. And inevitably, you're never going to feed in all of the right context, all of the right data. And so, we talk about hallucinations, but hallucinations are really just, estimations of what the data tells you.
A very simple example of when I do not trust AI is, and especially if I don't like when you're using a machine that doesn't show you the actual image that the AI is interpreting, is if you look at how bladder scanners work. In someone who has a lot of ascites or is on peritoneal dialysis, for example, you put a bladder scanner on and it'll say, the bladder has 999 milliliters. Obviously, you aren't going to trust that, and you need to go take a look yourself. That's just one example of, and a very simple one, right? Like that's low-hanging fruit for AI, and it still fails.
In tagging onto that, I think you should be treating AI like a pretty good medical student, like pretty good, but you wouldn't take it, you wouldn't make a medical decision off of it, right? At least right now, and so to Ria's point, going back and actually looking yourself, so we built a deep learning model to essentially interpret fast exams. And so the thing sits on the back of our ultrasound machine. But if your resident's not good enough to actually flash through the entire image, then it'll say negative, right? But if you're not actually picking up the blood that's on there, and so, like I said, AI is only as good as the data we give it.
Dr. Baum, did you have anything to add? I saw you unmute for a
Oh
second.
yeah, no, yeah. I would agree with those two assessments. I think we're starting to use it more in cardiac, and yeah, I think some of the studies have shown that it tends to underestimate LVEF, and a lot of times you might not be getting the optimal view, and especially when looking at the RV, a lot of if you get a foreshortened or a suboptimal view, it's going to underestimate the RV function. So I think we've seen that a lot with some of our studies in practice.
Evan's familiar with a project that we're working on, where we're not just looking at how one system automates left ventricular ejection fraction and IVC. We're looking at how a bunch of systems on the same simulated patient model grade these things, and it's pretty eye-opening. Evan, I know that you were also part of this experiment. We don't have the data yet, but just first blush, I think it would make you quite distrustful of AI currently in its current state.
Yeah, it's kind of interesting when the systems like don't agree with each other on the same patient, then you're kind of like, all right, what are we doing here?
Right. Same patient, same scanners. I think it's a well done study, and I'm really curious to see what the data is going to look like. But and then when you throw in, I'm not a neonatologist, but when you throw in the perinatal period, the remodeling that happens with the right ventricle, and you throw that data set into AI, what is that going to look like?
Along those lines, what level of validation should clinicians require before trusting an AI-derived measurement?
I don't know that I can answer that question. When did we start trusting an EKG to call a STEMI? I would say when we first started to look at EKGs, or when AI started looking at EKGs, I didn't trust it at all. And now I'm looking at EKGs and I was like, oh, I didn't pick up on that. But the AI did. So we're talking about, 10 years or more, I think, of um, teaching EKG machines to read. So is that the same sort of timeline that we're looking at for AI and POCUS? Probably, maybe a little longer.
I don't think there's a definitive like timeline, but it's definitely, especially in the field of neonatology, in its infancy. And so nobody should be expecting to just, be able to let the AI do its thing and go with it. We need to be questioning everything, and we know that we need to be, like you said, garbage in, garbage out. So we need to make sure that we're putting in the right data for the right patients in order to be able to implement and to develop some of these AI algorithms, which is it in and of itself is taking a long time.
Yeah, I think definitely larger, more robust studies, especially to see how it impacts like clinical outcomes. A lot of times these tools they're not telling you kind of how it actually has impacted clinical decisions or clinical outcomes in the patients that they're testing them on.
With respect to training, how can we make sure that trainees master the fundamental POCUS skills independent of AI? And how can we make sure they don't overly rely on AI?
I think back to Ria's point, at what point did we trust our residents not to look at the EKG reads? Like how many of your residents are actually just looking at that and being like, I totally agree with that, right? So when you think about downskilling, never skilling, I think we should trust our trainees to get to the level of mastery that we would expect them to have with the tools that they have, right? Like when I went through medical education, we already had EMR systems. And so I never learned what practicing medicine was like before UpToDate, before EMRs. I'm sure it was very different. But the people who taught me went through all of that. And they were like, you have to know how to do all of these things and sign a chart. Well, I never did that. So I think there is going to be a time when probably artificial intelligence is faster and more reliable and can tell you like, you didn't actually sweep through the entire cardiac window. And it's probably going to be better than our trainees. That being said, and just a little bit tying into the next couple of questions about whether or not there's going to be a commercial market for neonatal POCUS AI, and then the question about data. When you think about these big deep learning models that we have right now, that all of the major, GE, Butterfly, they've been building these data sets for decades, right? Like since Butterfly was invented, we were became a company. We were already, up in arms about, they're keeping all of our images and training models on it. And, we were upset about that in like the 2012s. And who has been doing that for neonatology, right? Like there hasn't been that product. There hasn't been that data set delivered. And so the question about whether or not there's going to be a commercial market, I'm sure there's a market for it. I'm sure nobody has the data set to answer those two questions.
And that's something that we're working on actually, because, as the largest neonatal hemodynamics program in the world, we do have a humongous data set of mostly small babies. A lot of every single baby that's less than 27 weeks gets a scan, within 24 hours, and then another one, at least one more in the next, few days. So we can get some of that data. Now, the problem is these are not 10 image scans, right? These are full echo protocols, where we're really trying to figure out the physiology. And that question is a very different question than, is this four-chamber view good enough for us to do an EF measurement? And so I think in those cases where if AI is telling you this is a good image, this is a bad image, we do that right now with our trainees, where we have a program that tells them that as well. I'm totally fine with you doing that. Like, go ahead. That's all you, because, it's helping you just get better data. I'm not saying that we should be using, any of those algorithms or models to say that, okay, well, this baby's fine, then we don't need to look at anything else. And that comes from the perspective of the hemodynamics faculty, which is saying, like, we should, if we do a cardiac POCUS, if we do a 10 image, or usually they're even smaller than that, they're just a few images to look at tamponade or to look at function and those kinds of things. We should be looking at the entire baby, the entire physiology, because there are a lot of things that if you've lived for 12 to 50 years as an adult, like there's things that in a baby that was just born this week, we could miss that if you've survived that long, like we're not going to be missing in you. So it's just a very different patient population as well. And so I think we need to look at neonatal POCUS and neonatal hemodynamics with a very different lens.
One of our attendees said that they think that one of the most useful ways right now for AI and neonatal focus would be within medical education, with some of the examples that have been shared. Are there any learning softwares available now for neonatal focus that incorporates AI that you all are aware of?
So I know I told, just like I said, one of our simulators has something that it's not necessarily AI, but it is something that it can tell you, it can grade you on kind of your imaging acquisition. And those I think are the most helpful for medical education, because, once you can actually get a good image, then that's when you can start measuring or making decisions on those things. And so I know that some simulators have that integrated. Again, those are simulators. Those are not like the actual tools at the bedside. So I'm not sure about those.
Yeah, I can only speak to, on the adult side, a lot of the systems, have basically learning programs within them, like anatomy-based learning programs. And we did a couple of trials here with our residents to test some of these kind of learning programs. The residents did, perform better with the AI tools in terms of scan acquisition time and image quality. But again, we weren't asking them to interpret the images, so it's just image acquisition.
Switching realms, what advice do you have for someone who wants to start a POCUS research project that incorporates AI?
I say be ambitious. I say go for it. I think 5 years ago, artificial intelligence was so difficult to get into, like who actually was building deep learning models back then? And, now you have kindergartners who can build deep learning models just based off of images, right? With Google. And it is easy. To Daniel's point, if you have a repository of images to build your own model, whether it's good or not, it's up to you to do your research to decide. But I say go for it.
I guess that question to me is pretty broad just because AI, the term AI is very broad, and so I'm not quite sure how you are envisioning using AI in the study. And as we have said, many AIs have not been fed enough data points, especially in the neonatal population, to really be accurate. And so I think that's coming, and I think that people who are very ambitious should do it with the caveat that we need to get really good data sets first. So an example, something as easy as beelines. Gosh, I've looked at the literature, and the definition of beeline isn't quite as stringent or stringently applied in the neonatal literature as it is in as I've seen it in the adult literature. And so like I've seen people sort of count Z lines that are comet tail artifacts that don't make it all the way to the bottom of the screen. In the adult literature, that is absolutely not pathological. In the neonatal literature, I have seen people count those as pathological. And so I think at the first step is sort of to get our definitions as strict as we possibly can so that we can feed the correct data sets into AI and then go from there.
I think there just has to be the realization that depending on where you're starting from and who you're working with and their experience as well, it may or may not be feasible in, kind of a short time period. There's different programs have kind of different, like if you're a fellow, you might not want to start something where you're trying to get completely done and presenting in 3 years when you're fully, like half of your time is going to be clinical or whatever. And then junior faculty, it's really going to be important to have that mentoring and to make sure that somebody has a data set that they think that it would be feasible for you to use and get good data from, get good information from.
I'd say that an opportunity for, some of these studies is once these products are developed, similar to, what Ria mentioned earlier, is they really need to be tested against each other and then tested against gold standards. And so I think that is an opportunity for research if you're not developing your own tool, your own model, but really, putting the developed models once they are developed under that stress test.
And people are always looking for that. Those of us that are actually developing, models, algorithms, deep learning, like we've got a whole gamut of things. We always need partners that will let us let it go on their data. And so, there are opportunities. It's just you have to know where to look and who to talk to in order to make sure that you're going to have something successful.
Dr. Tay touched on this briefly a few questions ago, but most of the data used for AI is well balanced with like a normal distribution. But how does it perform in difficult or more complex patients like micropreemies in neonatology? And will it be just as good in like regular or like what we call like easier cases?
Again, I think it depends on what you're actually looking at, right? So you're talking about like beelines and lung ultrasound and things like that. I mean, the lungs of the micropreemies are going to probably be the most difficult to get something on, right? But when you're looking at, so one of our machine learning models, we did only in micropreemies, only in less than 27-week babies, and it was perfect. It gave us, not perfect, nothing is perfect, but exactly what we wanted to get, we were able to get out of it. But there's still more work to be done in order to make sure that it's going to work on everybody. So just because you have micropreemies or just because you have a difficult patient population doesn't mean that you can't go forward and actually make things work.
The interesting thing about micropreemies is probe selection, even for something as what sounds simple as beelines, you really should have your focal zone at the pleural line. And in your micropreemies, like that is so close to the surface of the probe that like you really do need to have a pretty high frequency probe. But then the flip side of that is the higher the frequency the probe, the better resolution you have. Beelines don't quite show up the way that they would like in an adult, for example. And so there's that sort of tension there that I think is, just go back to the basics. What probe are we using? Are we all on the same page? Is it a convex? Is it an ultra high frequency? Is it a linear? Like, what are we using? What settings are we using sort of across the board? Where are we putting our focal zone? Are we turning off tissue harmonics? Are we turning off compounding and all of the things that we're supposed to be doing? And then can we sort of compare across the board? So I think we still have a long ways to go, but it's definitely worth the effort.
I agree with that. But then also with your micro preemies, if you do the most minute movement, the smallest thing, it can completely just
Mm-hmm.
change your image and you can just be nowhere anymore, right? Like
Mm-hmm.
the adults are much more forgiving.
Or you put a probe on and it's basically the whole baby. If you don't have access to a microconvex, I'm like, what are we looking at here? I'm seeing thymus all the way down to the diaphragm. Like, is that a consolidate? What is going on? So yes, very challenging in the NICU population.
What has surprised you all about most about real world adoption versus expectations of AI in POCUS?
I think it's probably similar to everything with AI at this point, where, there's literally people doing implementation science to figure out, why once we have created something, people aren't using it. Is it because we can't integrate it into your own systems? Is it, like there's a lot of different reasons for that. Um, and and again, it's going to be very different for neonatal POCUS than for regular POCUS. But that's one thing everybody has to think about when they are creating any type of algorithm or model is how implementation is going to go.
I mean, kind of taking the administrative side, Evan talked about it in his presentation, but holy smokes, I can't imagine why we are not integrating artificial intelligence into like QPAT, right? In synchronicity, because you can automate so much of that, right? Like if you're just in the room, we all have these ambient listening microphones. It would be so easy to say like, "Ooh, I see whatever in the right upper quadrant," and then boom, it's in your notes. It's already done. Somebody's already QA'd it. And so I think there is so much opportunity just from the administration, from credentialing, that we could be doing, that hopefully it takes off in the next couple of years.
Yeah, I would agree. I think it's, for example, at our institution, we're just getting people credentialed in POCUS for procedures, as well as for diagnostic POCUS. And, there's going to be one or two people who are going to have to credential everybody. And, it's going to be this, system where you have to put in a POCUS order, then you have to fill out a form, then you have to link that form to the study list on the actual machine, and then you have to interpret the image, like all that stuff. It seems like would be ripe for AI improvement. So I'm kind of surprised that that hasn't yet taken hold.
And what's one myth or misperception about AI and POCUS that you'd like to debunk?
I would like to go ahead and debunk the auto EF, auto VTI, auto IVCs as them being accurate.
Yeah, I think they're definitely leaving a lot to be desired in that sense. I think in some of these, controlled studies they do perform, but I think in real life and practice, you have to take your patient, you have to take everything in clinical context, and if you're deferring to that AI measurement, then I think that you're prone to be off in many cases.
On the flip side of things, what's one AI capability that you wish existed today but does not exist just yet?
Man, to Tom and Evan's point, trying to QA people who are just learning how to do POCUS and sending in, their portfolios, my kingdom for some way that I can just run that through a deep learning system and have it just spit out the ones where it's like, not sure, maybe this one needs to be manually graded versus all of these are perfectly fine versus all of these are just automatic fails. That would just save, I think, a lot of folks that are in the position where they have to credential others or teach others a lot of time and effort.
That would work for my hemodynamics fellows too. A lot more images, but that'd be nice.
Any other thoughts from the other panelists about that?
I would just say real-time feedback, like so often in the emergency department, at least, the residents are scanning on their own. And then you're going back and you're like, okay, next time go a little bit more lateral. And boy, that would be helpful in the moment. And it's not very helpful afterwards. And so, I know that, Evan showed off some software where it tells you kind of where to look, and, making that a little bit more accurate, because right now it's not super accurate, would be awesome.
Yeah, I would agree in terms of the educational component. So, as I mentioned, just better kind of like AI mentorship tools or just AI assistance tools to guide learners and guide people who are scanning, and then kind of cement that feedback so that they can kind of take it forward.
Okay, and we have time for one last question. What are some of the biggest barriers to implementing AI-enabled POCUS? Loaded question.
I think that in our experience and just kind of testing some of these systems, there's a lot of these are essentially companies are producing this, so there's a lot of kind of do these things actually are these things compatible? So there's like a lot of proprietary software that may not work across multiple systems or different devices, and so I think that's one of the barriers is that people are trying to make money off of these things, and that it often hurts the user experience and integration into clinical practice.
I also think
Yeah, I feel like this is high risk, like it's not like this is writing our notes or, pre-prepping, patient questions. Like if let's say, Danielle's model that she's building on micro preemies, it's going to take 4 years before it goes through like FDA approvals and all of that, right? And so like the anytime you're applying anything clinically and making decisions off of it, like, oh my God, it's going to be difficult to do anything.
Then also you have to, do it internally and then validate that internally and then validate it externally and then validate it in somebody whose patients are completely nothing like yours. And, there's a lot of steps before you can even start trying to get it to be implemented elsewhere, if you're doing it the right way, right? So I think it's just there's a lot of barriers, but also we're just, we're and it's in our infancy, like when it's coming to neonatal POCUS and or hemodynamics or whatever you want to talk about with AI. So there's a lot of people interested in it, but there's a lot of work to do.
I will say the barrier to entry has never been lower. You get a $3,000 Jetson put on the back of your machine.
This has been such a wonderful and engaging session, but unfortunately, we're out of time. I'd like to thank our speakers and panelists for sharing their expertise, and thank you all for joining us. In the chat, you'll see the link to the NeoPOCUS Collab website where you can find all of the recordings of this webinar along with prior webinars. The webinar series will be taking a break over the summer, but make sure you're subscribed to the NeoPOCUS Collab's emails so you can receive details about upcoming learning opportunities. And thank you again for joining today's webinar. We'll see you all in the fall.
Thanks so much.
Thank you.
Thank you.